From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Hello, this is Dr. Jeffrey Saber, the JAMA Associate Editor for Neurology, and welcome to JAMA Author Interviews podcast. We are very lucky to have with us today Dr. David Greer. He is professor and chair of the Department of Neurology at the Boston University School of Medicine, a renowned intensivist, researcher, and educator, and he is the lead author of the Intrepid trial, now being published in JAMA, which we'll be discussing today. Welcome, Dave.
Thank you, Dr. Saber. Great to be here.
Well, let's begin with the background for this study. What led you and your team to undertake this trial?
Sure. So we've known for years that fever has been associated with worse outcomes in patients who've had a stroke. And that's regardless of whether it was an ischemic stroke, a intracerebral hemorrhage, or a subarachnoid hemorrhage. If you had a fever, especially in the early going after having your brain insult, you did worse. But what we didn't know was whether preventing that fever and keeping people from having a fever could improve outcomes. And so that was really the premise of the study, is being aggressive by preventing fever up front versus what we typically do in the intensive care unit, which is let people have a fever, treat it, they get another fever, we treat it with something else, and somewhat chase our tails. So this is a very upfront approach to try to prevent the fever and keep people from getting a fever to see if it improves outcomes.
And a key aspect of this study is the particular interventions in both arms that you did for fever prevention. Can you describe each of them a little bit?
Sure. So in the fever prevention arm, everybody got put on what's called the Arctic Sun device, which is an automated controlled temperature device where you have pads that adhere closely to the patient's skin, and there's water that's running within the pads, and that temperature of the water can be modulated up or down depending on what the patient's temperature is. And so, as you can guess, you have to have something that's continuously reading the patient's temperature, which in this case was either a bladder thermistor or an esophageal thermistor in patients who were intubated, because these machines are great at keeping you really tightly clamped around a certain temperature, that if your temperature starts to go up or down based on what's going on in your bladder or your esophagus, the water temperature changes right away to keep you really clamped at a certain temperature. And for this study, the temperature was 37.0 degrees, and within a half a degree around that was what we were really aiming for. In the standard care arm, it depended a little bit about what center you were in and what drugs were available, because we did have international sites. But in the US, we used things like acetaminophen if somebody had a fever. And in the European sites, we used more paracetamol and medications like that. If they failed with that, then you could step up the therapy by using cooling blankets. You could use ice packs, fans, tepid baths even. And really, as a last resort, after they failed everything, they could go on an automated device as well if that was needed to try to get their temperature or fever under control. So those are the two arms and how they were treated a little bit differently.
Thank you. Can you tell us about the size of the trial and what were the main findings?
Right. So the size of the trial, initially, we were aiming to have almost 1,200 patients in it. And we did a planned interim analysis after we had enrolled 686 patients, of whom we had a primary analysis population of 677 patients because 9 were excluded. So they were consented but not randomized. So at that interim analysis, we hit a stopping point that it was very clear that if we continued the trial, there was not going to be a difference in the functional recovery, which was the secondary analysis, or the principal secondary analysis that we were looking for as a functional recovery. And that's why the trial was stopped after enrolling 686 patients.
And so you succeeded in getting the temperature better controlled, but it did not make a difference in the clinical outcome. Can you talk about the amount of increased temperature control and what the clinical outcome was?
Sure. It gets a little bit complicated because we used a statistic that made sense and still makes sense, and that was degrees Celsius per hour. But what we looked at was the amount of temperature above the fever curve, which was anything greater than 37.9 Celsius. So it was the amount of the temperature and the amount of time that we wanted to account for as well. So it was the patients who had the degree of fever above that measuring point divided by the number of hours and then multiplied that by 24 hours. So it sounds like a very complicated statistic, but this was the way to capture really the area under the curve of the patients who had fever and for how long. And we showed that we could actually prevent fever, and that was actually very important. If we had a negative clinical outcome, but we hadn't actually prevented the fever, then we wouldn't have actually shown anything because we didn't prevent the fever. But we did prevent the fever, which was good. And that was really across all the different stroke subtypes for both ischemic stroke and intracerebral hemorrhage and subarachnoid hemorrhage. And so that was a significant difference for all three of those groups.
But the final disability outcome, the level of disability, did not differ between the groups, and that led to the early stop of the trial. Let me ask, were there any surprises in the trial findings to you or any important limitations our listeners should know about?
We were surprised because we thought that if we did control fever, we would have seen a difference in the outcomes. And so there are a few things to maybe keep in mind. First of all, even though it sounds counterintuitive, people who are kept normothermic still can shiver because if they're trying to mount a fever, the water in the pads is going to get colder, and that's going to make them feel colder because it's on the outside on their skin. And so they'll shiver. And we didn't realize how much shivering there actually would be. And so one of the early lessons learned in the study was that you had to really jump all over the shivering early on. I think we got very good at that as the trial went on. But in the early going, we had some patients who surprisingly shivered quite a bit. That probably tells us that those were the right patients to include in the trial, though, also because they were trying to get fevers and we were preventing them from having fevers, which was the whole point. But maybe if we had from the get-go had been able to jump on the shivering a little bit better, maybe that would have helped. We also didn't see as big a difference in the temperature difference between the ischemic stroke patients. It was still a significant difference, but ischemic stroke patients don't get as much fever as the patients with blood in their head. And so maybe if we were to think about a future trial, maybe we would focus on only those who are at highest risk to get fever, because about 30% of the patients in the study never got a fever. And so they wouldn't benefit being on a fever prevention device. Lastly, I would say that the patients who were easiest to control from a shivering standpoint were intubated patients. And that's because you could give them more medication. And so again, as you think about future trials, thinking about the sicker patients, the ones who would be most likely to benefit, the easiest to control from a fever standpoint, but are not so far gone that they wouldn't benefit. So patients with catastrophic injury, for example, would not be good to include because we may not impact the outcome of them regardless of what we do.
Lastly, let me ask you about the immediate clinical impact of these findings. These devices to control the temperature to a tight target are in fairly wide use and certainly widely available in neurocritical care units. Do you think clinicians should be changing how they apply them in vascularly injured patients?
Well, I think that's a great question. It's unclear based on the results of our study to say that. That being said, it's pretty hard in the ICU setting to stand by and watch a patient get a fever and get another fever and make it refractory. And I think that this study provides really great data that these devices work and that you can clamp people, but you have to be very careful and make sure that you're treating the shivering aggressively. And treating the shivering means also detecting it because patients may have micro shivering. So you have to feel around the neck, the platysma muscle, and feel for micro shivering because that can generate a surprisingly large amount of heat, just this little micro shivering. And then once you detect it, being aggressive with trying to treat it, and we have a really nice algorithm for medications that are non-sedating first that get to more sedating medications. So I think that this does help to move the field forward, that people will use this to control fever probably more aggressively than they had in the past. But I just want to make sure people understand we still have yet to prove a benefit in terms of functional outcomes, but let's not close the door on that because I do think if we identify the right population and study them assiduously, we can hopefully come up with a different answer.
Yes, and this certainly was a trial of two ways to control fever. There was nobody whose fever was being allowed to run free. I am Dr. Jeffrey Saber, and I've been speaking with Dr. David Greer about the Intrepid trial of fever control in patients with vascular brain injury. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network. Thanks for listening.